My respected teachers, seniors and colleagues, what can be the better beginning to start a year 2021, going through the toughest times of our lives post-pandemic, the COVID 2020, and that also with the blessings of our sir, Dr. G.V. Merchant sir. On behalf of Baroda Orthopaedic Association, I, Dr. Alpesh Parekh, Secretary, welcome you all to the annual Dr. G.V. Merchant Oration. Also not to forget, today is 24th Jan, the National Girl Child Day. So wishing all the lucky fathers for their wonderful girl child at their homes and praying God to keep them healthy and wealthy. Just I'll share my screen. Just a minute. Is it clear? Visible? Hello? Hello?
Yes, sir.
You are
Yes,
clear
sir.
and visible.
Yes, it is visible.
Yes.
Should I proceed?
Yes, please.
Yes, yes.
Okay. Dr. Gopal Varjivandas Merchant was born in Kheda on 19 September 1921. He joined GS Medical College, Mumbai in 1939. He did his post-graduation in surgery under Dr. R.J. Katrak in 1952. After a short period of time of 9 months at the Tata Cancer Hospital under Dr. Borges, he came down to Baroda. Dr. Merchant joined Medical College and Sir Sayajirao Gaikwad Hospital, Baroda in 1954. Starting from a department, he built up the complete and the competent department of orthopedics of worth, quality and repute. He was the first he has got period of time of 9 months at the Tata Cancer Hospital under Dr. Borges. With his vision, wisdom and planning, Dr. Merchant was successful in establishing first school of physiotherapy of state in 1969. Second, first spinal injury unit of the state. Third, first prosthetic and orthotic workshop of the state. On his personal platform, he was quite a diligent clinician, surgeon par excellence, tough taskmaster, who had nothing like no in his dictionary, and above all, the virtual father and founder of orthopedics in Baroda. He left for the heavenly abode on 28 Jan 28 to continue his academic zeal, and in his memory, Baroda Orthopaedic Association Oration has been declared as Dr. G.V. Merchant Annual Oration. Thank you. And let me quote for Merchant sir and all my teachers and all colleagues who are my teachers in some or other way. Without teachers, life has no class. So Sejal, I hand over the baton to you and introduce our guest. I'll stop sharing my screen.
Thank you, Alpesh. Today on this G.V. Merchant Oration lecture, we have very well-known, renowned robotic joint replacement surgeon, Dr. Narendra Vaid. We welcome internationally acclaimed joint replacement surgeon, Dr. Narendra Vaid. I welcome you, sir.
Thank you very much.
I will just give a small brief introduction of the Narendra Vaid. He has passed his MBBS from the BJMC, Pune in 89. He passed his MS Orthopaedic from Pune University as a gold medalist in 1994. And he is trained over by the Dr. Sanchetti, and in US, Sweden, Germany, and many more places. He has many things in his profile, starting from the invited speaker and panelist in Indian medical tourism destination at Dubai and Muscat in 2015, to the regional forum of SARC and Developing Association organized by FICCI and by the Ministry of Commerce of Government of India. He has also got social contributions to the Golden Hour project in 1996, instrumental in saving life of 1.5 to 2 lakhs trauma victims. He has numerous paper and seminar presentations in his name, and it is a long list from the DEPU to the FAPEC to the MOACON to the Navio Robotic Master Meets, ISACs, and lot many. It is a big list, which is, if I start telling, it will take half an hour. He has been awarded as a Rashtriya Ratna Award, one of the 100 most impactful healthcare leader in India, Sanjeevani Pariskar Award, Mahindra Navistar Award, Vishwa Vivek Puraskar Award, Maharashtra Times Icon of the Health 2019 Award, Lokmet PCM Icon Award, and lot more. He has more than 50 plus presentations and 100 plus talks nationally and internationally. He is a PG teacher, professor, faculty, and even he trained the fellows for the joint replacement surgeons. His area of interest particularly is in the hip and knee, shoulder and elbow, and he is in pioneer in introduction of robotic joint replacement surgeon in India and in Lokmanya Tilak Pune Hospital. And he has also got his contribution in the Orthopaedic computer assisted joint replacement first time in the Pune also. And he is Overall, he is also managing director and the chief orthopedic surgeon of the Lokmanya Tilak Hospitals group of hospitals, and he has got excellent contribution towards overall development of the Lokmanya Tilak Hospitals group of the hospitals. I welcome you all. I welcome you, Dr. Narendra Bhai, and on the behalf of the Baroda Orthopaedic Association for the GV Merchant Oration lecture. Sir, stage is now yours.
Thank you, Dr. Sejal, for a kind introduction. First of all, I am very much glad and thankful to the entire body of the Baroda Orthopaedic Association for inviting me and giving a chance to present my work and my thoughts about robotic joint replacement on such a beautiful platform. And especially this more merchant oration lecture has been really an honor to me. So I'll start sharing my screen now, and I'll proceed with the talk.
Yes, sir.
Okay, can you see my screen?
Yes, sir.
Yeah. So this is Lokmanya. I'll tell in brief. We have 5 hospitals across Pune and western part of Maharashtra. This is one of the hospitals in Nigdi part of Pune. We have one Chanapati Bapat Road, and then Chinchwad, and in Kolhapur. So this is the hospital where we used the first robotic robot. We did a first robotic assisted knee replacement in 1996, and till date now we have crossed more than 5,000 robotic replacements, and it is the highest number in not only our country but in the entire Asia Pacific and probably globally also. So we all know that total knee replacement is one of the most successful surgery, and it has given new life to numerous people. And it has really helped a lot of people who have been, crippled because of knee pain, terminal knee arthritis. But now today, if you see, the total knee replacement is not the only thing in the armamentarium of a particular surgeon. And we can offer so many treatments for a knee arthritic patient. So there are still dissatisfactions in total knee replacement. So there is a lot of dissatisfaction. Patients are not that happy. The surgeon does a good job. He gets everything right. And still about 25% patients, if you see the global literature, they are still dissatisfied. And various reasons like enumerated here are there, which will make 25%. That means 1 patient out of 4 patients is going to come in your OPD in post-operative phase and eat your head. So this is really a problem, and so we need to address it. So we have not reached up to the optimum level as far as the total knee replacement is concerned. I think there are various things which are important in total knee replacement. The progress has been in tools, the implants, design, materials, techniques, that is MIS, CR, Express TKR, Uni, etc. And the technology. The technology also has helped a lot. That is navigation, the ortho-align, and the robotics. So these developments of TKR have been around these three T's. Improvement in the outcome. If we see, then two variables, that is the implant design and accuracy of implantation, are the most important, determinant of the overall outcome of total knee replacement. There are a lot of implants with many new thoughts and different geometries, etc. But actually speaking, there is no evidence saying that there is some impact on the outcome with any one particular design. They're all similar. So X joint is better than Y joint. That doesn't happen. If you do any joint properly, they'll give almost equal results. But accuracy of implantation is the most important determinant, in my opinion, because it affects the results to a great extent. Accuracy of determining the center of femoral head, center of knee, ankle, the physiological interpersonal variation. There is too much to depend on surgeon's perception, preoperative planning, etc., which may go wrong. And so accuracy of implantation is dependent on so many factors which can go wrong. Also, there are some patient factors. You see a lot of patients with huge obesity, high, big girth of the thigh and the calf, so you don't get full flexion. To assess these people is very difficult and things can go wrong. So these patient-dependent and the surgeon-dependent factors may lead to non-optimum alignment in total knee replacement. There are so many variables in the total knee replacement. If you have to get a correct alignment, that is the center of the head, center of the femoral flexion extension, distal femoral cut, thickness, rotation, varus, valgus. So there are so many things. I calculate there are almost 48 variables in total knee replacement. If you err by even 1 millimeter, a simple thing like entry hole, err by 1 degree, then there will be 2 degrees of error in the final alignment. So it is, the margin of error is very, very small. And so things can go wrong. Tibia also, the resection level, varus, valgus, slope, internal, external rotation of tibial component. So these variables are there and things can go wrong. You might apply a jig properly, but the saw can oscillate, and at the same time, it can wobble and take out more bone from the osteoporotic area and skive off the sclerotic area, giving an uneven sort of a surface on the top of the tibia. So there are errors which are beyond the jigs. Jigs may be good, but they can still produce a lot of errors. And you have so many instruments to tackle with, so many implant companies with so many different designs. So there are n number of variables when we are all doing arthroplasty. I have been doing arthroplasty since about 28 years now. And earlier part, I used to use navigation, conventional. So I have got a huge exposure to all the technologies, starting from conventional to robotic assisted knee replacement. And things can go wrong if you are tackling with so many variable instruments. If we see this paper, then amongst even high volume surgeons and experienced surgeons, outliers can be 30%. It is huge. So outliers are defined as the alignment which you get post-operatively is 3 degrees or more than planned alignment. So 3 degrees and more is quite huge. If alignment is not correct, then the joint is going to wear, joint is going to have a septic loosening and going to early failure. And most of the failures go to revision within first 3 to 5 years. So this is quite a important factor which one should keep in mind. If the alignment is like this, then there are of course going to be immediate disasters, and I hope that nobody does replacements like this. But things I have seen, I have revised many of these, and you can get problems. So if we see, total knee replacement is a soft tissue surgery. That is what has been taught. Who decides the soft tissue release is adequate? Because in every conference, every talk, everybody says that do an optimum release. So what is this optimum? In my opinion, optimum may be 2 millimeters. Some other person can be having 3 millimeters. So this is a very, very subjective term. And we are all teaching our students, we are talking the same language in conferences, कि भाई optimum release कराना है. So there is nothing like optimum, it is very broad definition and the margin of error is very high. So what if we have an equipment and take help of science to objectify this particular soft tissue release? So our advances have been now with robotics are focused on improving surgical technique, kinematic balancing, optimum and minimum calibrated soft tissue releases, perfect post-op alignment. So these are the aims for the total knee replacement. So computer assisted surgery was an innovation in late 90s, and it definitely helped to a certain extent, increases the accuracy. Early post-operative rehabilitation was documented. But navigation has got certain limitations. It increases accuracy, enables the surgeon to understand the knee deformities better, helps in especially beginners in balancing the knee. But I think navigation is somewhat like a good intraoperative diagnostic tool, which is sitting on the side of an operation table and which helps in planning, but the execution part is not there in that. And that is where robotics comes in play. So it helps us in putting a jig. And I know that the errors related to skiving of the saw or dipping of the saw and slipping of the jig, they are all there in the navigation. And so navigation, it went into a bit of a disrepute. It went out of the fashion, and now very few people are using navigation. Also, there is an error which people do, that they call navigation as a robotic technique. So navigation and robotic, there is a C difference, which I will be telling. And the main difference is that the robotics has an execution arm which can actually execute the plan which we have planned on that particular patient. So what is what if we have a system which helps us in alignment in all three planes, gives kinematic alignment? This is most important. Actually, now the philosophy is changing from mechanical alignment to kinematic or physiological alignment. It gives appropriate gaps, not only in 90 degrees and extension like we do in a conventional TKR, just put the blocks and see that, but it gives balancing in all the degrees of movements, right from full extension to full flexion. So a surgeon is able to visualize the balancing throughout the range of movement. And so it addresses the chronic issues like mid-flexion instability. It also allows us to objectively analyze the ligaments and helps in ligament balancing. So that's the most important thing. So that term of adequate release actually becomes very, very much possible with robotics. It enables to execute the plan to absolute perfection. So let's see, what is a robot? So this term was derived from robota, which means forced labor. Robot is a machine, especially one which programmable by a computer, capable of carrying out complex series of actions automatically. So there are two types of robots. One is humanoid robots, which is Sophia, you all know. And then there are non-humanoid, which don't look like a human. And all the orthopedic robots are non-humanoid robots. So the history in orthopedics is quite long. They started in 1988. CT-guided brain biopsy was done by Puma robot. Then Pro robot was developed in Imperial College for prostate surgery. Robodoc was the first orthopedic robot developed for total hip replacement. And then there was a lot of evolution which has happened over years. And we have three types of robots. Active robots, where surgeon is out of equation, where robot will take place of surgeon. Surgeon has to expose and give everything to the robot. They were quite popular some years back, but they went into disrepute because of certain complications, because machine doesn't have a tactile feedback mechanism. And when they use the active robots for totally replacement, like Robodoc especially, there were some complications like shattering of bone, etc. So now whatever robots are being used are semi-active or semi-haptic, which take tactile feedback systems, require surgeon to manipulate, and the robotic arm is there, either flexible or rigid. And the surgeon is always in control. That is the most important development from the old active robots. Now, there are some active robots being brought in our country, but one has to be very careful if you have to go for that technology, because active robots had gone out of the fashion and now they are reintroduced in our country. So these are active, Robodoc, Casper, these are all active robots. Passive systems are like navigation. They don't actually participate in the action, that is the execution. Currently, if you see in the world, there are 159 surgical robotic systems are being developed. So you can imagine the robotic revolution which is going to come. Some surgeons, some colleagues don't like robots, but it is nothing personal. You have to take it. You have to take help of the technology. Ultimately, it is going to give you a more accurate joint. Well, I feel how it is that is going to be not how I feel it is good joint. The terminologies are going to become more objective, and definitely there is a role of technology in life. So how this robot works, let us see. So initially these robots is semi-active. Now both the robots I'm using are semi-active or semi-haptic. I have 3 Navio systems and 1 ROSA system, and I've been using in many cases today. Around 40% of my practice is on robotic joint replacement. Other patients, because of various reasons, they opt for still conventional knee replacement, but 40% is a big volume. Annually, normalized conditions, we do around 5,000 joints annually. So these robots I use in mapping planning. They help in surgical action, milling, sculpturing. Surgical actions are constrained, adjusted by the system. They work in haptic boundaries. So the burr goes out or deep than the haptic boundaries, then it will stop executing or stop rotating. And that is how they will, not cause more damage to the bone. So Navio and Mako, they are 2 semi-haptic sort of technologies. So Mako is a bulky machine, and it will be it is a CT-based machine where you have to do scans, and then you can see that handle is quite handle is quite bulky. So to manipulate this thing from one OT to other can propose problem. I'm not having Mako in our hospital. Navio is a 2nd generation robotic system which is image free. Only handheld robotic instrument is there with high speed burr, which operates in 2 modalities. That is, one is exposure control, and second is speed control, which revolves at around 80,000 RPM. And so this sculptures or carves the bone. So this is how it works. I have this ROSA system also, which is a robot which places the jigs, and you have to take the cuts with the saw only, but you can balance the knee completely. They have now all models of Zimmer, which can be implanted using ROSA, and very soon for uni also it is going to be used. It is X-ray based, imageless, so there is no intramedullary intervention required. So these advantages are there for ROSA. 3-dimensional assessment of the deformity is possible in any robotic system. I'm going to show some cases, interesting cases also in the later part of the lecture. And then we can do all the adjustments in femur, like flexion, extension, varus, valgus, anterior, posterior translation, internal, external rotation, so slope, cut depth, everything can be pre-planned. And the beauty of robotic system is that you can virtually do the surgery before actually you cut the bone. That is the most important thing. And the surgeon is always in control and can use robot in multiple ways. So I'm just going to show a small video how the robotic arms, to give you a feel how robotic arms work. So first, after standard exposure, this is a ROSA robotic arm, which will take a spatial orientation, and it will completely go around the knee and take orientation of that, and then the arm will be setting in a resting position, and then it will apply the jigs whenever it is ready. So these are 9 positions which the ROSA robotic arm will assess, and then it will go to the resting position. So this was about ROSA, and then you can get all these screens. You can see medial gaps, lateral gaps, then what is the flexion gap. You can adjust the implants accordingly to get the values absolutely right. So your knee is snug and whatever way you want, and actually plan and virtually do surgeries on the screen first, and then go for the actual execution part. And then once the planning is done, this robot will place the jig on the bone, which is actually removed. So you can see the arm coming there. So there is no intramedullary rod or anything. So there are 3 modes. This is the assisted mode where the jig will sit here, and then with 1 pin, the leg gets fixed with the robotic arm. So even if there is a movement of the leg, the arm also can move, and you don't have to adjust it again. So there is very much work and time efficient. And then you cut the bone with the saw. Similar thing for tibia also, it will take its position. You can assess the implant after post-trial. You can assess it, how the leg is moving, how are the gaps, and then remodify your cuts if required. So you have a lot of literature now, and I'll go through it. There are some drawbacks in conventional surgery. Many surgeons don't accept it, but I think keeping a blind eye on the literature is not going to really help those surgeons. They have to read the references in so many index journals that there are drawbacks and limitations of conventional surgery. We all were doing conventional surgeries for more than 2 decades, but there are a lot of drawbacks. Advantages of robotics is that it gives us a virtual mapping. It works on a virtual 3-dimensional model and helps surgeon to achieve a desired bone coverage with the implant, limb alignment, deformity correction, kinematically assesses throughout the range of movement. This is most important, and execution of the resection. And we get rid of all the instrument trays, and only one intelligent handpiece is there with the surgeon. So it is very convenient for us to actually do the case. So all these things are possible with this, and surgeon is always in control. This also helps in objectively training the next surgeon. When we used to be residents, boss used to ask us, "Kya boss, sab theek lag raha hai na?" So resident has no option but to say, "Yes, sir." Otherwise, his dissertation won't be signed. Now there is nothing like this. The boss cannot ask a question, "Sab theek hai na?" And if it is theek, then the computer will show that it is correct. And there is no actually denying if the balancing is not correct. So it is a very objectively balanced knee, and you can give this record to the patient also. It helps in medical legal problems also. If somebody challenges, if the patient is having pain post-operatively and says, "Operation theek nahi kiya," so there is a definite evidence saying that, see, these were the balancing and the things were done absolutely perfectly well. So this is the way, other sort of benefits are there. So I'm going to take you through a small video of a unicompartmental, because as I told you, UK is now re-entering the surgeon's armamentarium. Almost 15% of my practice is unicompartmental. And with robotics, it has really given us a great tool to achieve a really consistent, reproducible alignment in all the cases. So you see the X-rays always same, not like this. And you can actually get a perfect alignment in all 3 planes, long leg alignment, resection level, tibial resection level, everything is perfect. So this is a short clip how UK is done. I'm going to run it fast. So with a standard small incision on the medial side, you expose parapatellar incision. You can see completely one condyle, which is completely degenerated. Then you can apply these tracker pins. These are 5.5 tracker pins, which you have to attach on the bone. It has to be firm and it should not move. And then we assess the leg through the range of movement, non-stressed and stressed range of movement, and see what is the condition of the ligaments. I put a Z retractor in the compartment, and you can see now I'm applying a stress and how the joint is opening. So that gives me an idea of the MCL, the tightness of the MCL. And then we start moving the tracker on the bone, as you see on the right-hand side picture, and it creates a real-time virtual image of the femoral condyle, whether it is a uni or whether it is a total knee replacement. And you get a beautiful picture of the femoral condyle. You can rotate it also and see the backside, so you know whether you have painted adequately, and that's correct. The posterior part of the condyle also has been corrected. And always a reference of the axis is there, so rotation of the component also can be adjusted. So this is the way how we plan. After planning is done, we can actually do plan and move it, see how the prosthesis is going to fit. We can slide it anteriorly, posteriorly, take the depth, see actually what is the slope, because all the systems of unique compartmental, the success of conventional success depends on the first pin which you put on the tibia for the jig, because all the femoral components placement is most of the systems based on the tibial component. And you can see the balancing. So here in the balancing screen, we can see we have corrected from 4 to 1 degree. It can also show how the pressure is going to be distributed. You can see virtual movement also, how the prosthesis is going to behave. And the beauty is that all this happens before actually you start cutting or removing the bone. Then you get a 3D model of the a bone, there is a color coding. Red is more than 3 millimeters bone, then blue is 2, green is 1, and white is what we want to go. And then with exposure control or speed control, you sculpture the bone. It is very fast. The burr is revolving at 80,000 plus RPM. And so it just with single instrument, you can remove the bone of the tibia and femur and get a good alignment. So a nice surface is created for that. And then use cementation and perfect alignment you can be achieved in all cases. There is no variation. All the units will be perfect. And all of you know that the life of unit depends on the accuracy of implant. That is the most important determinant. So that is how the uni is very important. Now you can start doing uni compartmental replacements. And perception about robotics is that it is very time consuming. Yes, there is a learning curve, but you can see that it comes down drastically as you go on practicing. So now it is around 17 minutes for me for uni compartmental and about 24 minutes for total knee replacement. And you get consistent alignment and consistent x-rays like this. And you can see so many cases being done, and the x-rays will be uniformly good. Now see the literature of uni compartmental knee replacement using robotics. So Justin Cobb has mentioned, and he's a chair of orthopedics in Imperial College of London. He says MIS UK will become the first choice of operation of osteoarthritis knee, and robotics has much more was accurate. So you have to take that word and start doing robotics. There are a lot of literature which suppose this. There are no outliers in this study for robotic assisted UK. So accurate and reproducible plan. So there are, this is another important paper where they have documented that 55.4% less pain in the robotic assisted group. So there are a lot of changes in the outcome, because the initial pain is less, the patient is mobilized faster, accuracy is better, so the long-term survivorship is better. So there are a lot of advantages in that. Now let's go to the robotic total knee replacement. So we can have mechanical, hybrid, or kinematic alignment. You can use distal burr, all burr, and there are jig placement also. So there are a lot of options in with the surgeon. So again, we do mapping here, like I showed in uni. A three-dimensional virtual model is created by the robot, that is Navio, and works on desired bone coverage, limb alignment, and kinematically assessed throughout the range of movement. So mapping means we just move the tracker on the bone, and you can see it virtually creates an image of that particular femur. It is very fast. You don't have to actually, any small child also can do it. So there is no scope for any mistake here. So this will calculate the posterior condylar axis. This will calculate the epicondylar axis, white side line, everything you can get. There's nothing left to imagination. When I talked about white side line, you know that there is a variation, interpersonal variation of almost 2 degrees to 9 degrees, which is huge when we talk of, a rotation of the femoral component. So why we should be, rigid that, okay, I am good with this particular method, because you are every time likely to go wrong by 7 degrees. It is too much to ask. So similarly, tibia is also painted. You can see nicely all parts of femur are being painted. You can draw on the tibia also. So nothing left to imagination. So we know the slope of tibia, the rotation of the femur, what are the sizes, nothing left to imagination. So after this mapping is done, then you can do planning and then execution. So this was about mapping. Next is about the execution. You can do it a distal burr. So this is a very fast revolving burr which you have to move on the tibia, and you can see this virtual image. Arthroscopic surgeons can do this faster because they have habit of looking at the screen and then they operate here. So the way we used to do total knee is changing. I look at the screen and operate on the knee. So this is how completely execution is important, and this is a big advantage over conventional surgery as well as the navigation surgery, because navigation does not participate in the actual surgery. So most important key factor is planning, and planning I think is most important. And to get it right, you have 3 philosophies. Initially, you should go by mechanical alignment. The more you get expert, then you can go for kinematic and sometimes hybrid paths. So I'm going to discuss some cases and give a guideline which protocol can be used for which one. So when correctable deformities are there, you can go for mechanical alignment and major dissection. Don't have a stressed range of movement. So this case, 55, 4 years old rheumatoid with valgus, 20 degrees valgus. So bilateral case. So we did bilateral single sitting with Navio. So this is a screen which comes initially, and you can either take joint collection, skip. So that means I am doing a mechanical alignment. If you want to do kinematic alignment, you have to edit it and take collect. So that is a system there. Initial registration takes about 2 minutes. And then you get this picture where you can adjust the prosthesis. You can see on the top left-hand side, the initial placement is 0 degrees, 0 degrees by default position. You can tweak in all three planes and try to get a good balance. So this is the final post-op gap balancing. You can see absolutely straight balancing is there. And from 11 degrees, we corrected it to 2 degrees. And the beauty is that we don't have to really release any substantial soft tissues. You get it with adjustment of the prosthesis on the bone without disturbing the soft tissue envelope. And so the pain, the overall proprioception of the patient post-operatively is much better than the conventional knee surgery. And this is the post-op X-ray. So you can go for kinematic alignment where you take the, you can see here the joint laxity collection is mentioned here. You can take anterior or posterior referencing, no problem. Again, this is the by default section. Now this case, the varus was 8 degrees, so not a very severe varus. So we are going to take this, the pre-op gap assessment, where you can see orange is very tight near the midline. That means the medially contracted joint, and the blue lines are going up. So that means the lateral compartment relatively is lax, or there is a medial defect. So after balancing, I have done now 2 degrees of varus in the femoral component, and see how beautifully it is balanced. So both the compartments are in flexion and extension balanced within 1 millimeter. So that is the great sort of achievement which we get an objective assessment. So if you compare the graph on the top, which was pre-operative, and this is post-balancing, you can see a uniform graph, and it is the joint is within 1 millimeter from entire range of movement. Like I mentioned before, the balancing can be tested in the throughout the range of movement, and not only 90 degrees and full flexion. So it addresses the mid-flexion instability issue as well. And you can have this final screenshot. This is the X-ray. Another case where 17 degrees varus, which was partially correctable, bone defect on the medial tibial condyle. And here again, we are doing by the by joint collection, laxity collection, means kinematic alignment. So here we can see this sticky picture and this routine picture from 0 degrees. Now see the next slide. This was the picture in balancing, pre-balancing picture. Now here the most important thing is that we are tweaking the prosthesis on the bone and adjusting a bit by a couple of degrees of varus and valgus without releasing the ligaments. So ligaments are more or less kept intact in partially correctable deformities. If it was non-corrected deformity, yes, you have to objectively go on releasing the ligaments, taking help of the Navio or the system which you are using, and then correct the contractures. So here, this was the first screen. Now here I did was 2 degrees of femoral varus and 1 degree tibial varus. So combined varus was 3 degrees. I never crossed 5 degree combined varus, and most of the adjustments are on the femur. I try to keep the tibia as horizontal or 0 degree as possible. So you can see that this is more or less within 1 millimeter. The 1 millimeter down can be, corrected by taking out the meniscus and a minimal release, and which you can see. And this is how the post-operative alignment can be there. So you would know what releases you are doing. You can see that and actually correct it. So there is another case which was a bit of a complex 3-dimensional deformity. There was a malunion at the proximal tibia and a 3-dimensional deformity with a combined varus of 23 degrees. And you can see there was a malunion with a varus there. And most importantly, in the sagittal plane, the slope was, deformity was 19 degrees. It was not apparent as it is, but we measured to 19 degrees. So in conventional, there are a lot of challenges like mentioned here. So these all challenges can be easily tackled with only one instrument, that is the robotic. And we can collect this thing, again, the same thing. And you can see the balancing screen like this, where you can see the orange one below the line, and it's very tight medially. So there is going to be tight contractures, which we release. See again how much we have released, and we can actually measure how much soft tissue releases are being done. People have a misconception. Many colleagues, eminent colleagues, say that this robotic is nothing but bone removal system, bone burying system. It is absolutely wrong. You can actually assess the ligaments. It's a soft tissue thing. Execution of the surgery ultimately has to be bony. You have to remove bone in any type of TCAR, conventional, robotic, or anything, because that is a bone removal has to be done. But the ligaments are respected here. This just, I've heard many people saying MCL is a mother of all the knees. Yes, right, agreed. But then why release that MCL to a great extent and make it completely weak? You don't play with your mother beyond a certain limit. So you shouldn't be, you should respect this MCL and do alignment of the prosthesis on the bone by sculpturing the bone and get perfect alignment like this. So there is a digital angel wing also. You can reassess your cuts. Now, you can see here the slope after initial cut has reversed by 1.5 degrees. So these are to go unnoticed in conventional surgery because we can't measure this, but they can have dire consequences. So to tackle it, we can burr it. Now here we can refine this cut by burr and make the cut absolutely perfect like what we planned. So 3 things. One is robotics. It will give you a perfect idea of anatomy and morphology of the bone. Number 2, it will give you an instrument for planning. Number 3, the most important thing is that we have a tool which will execute the plan to perfection. There is no gap between planning and execution. You get always wherever you want it. And in this complex case, you see the preoperative planning balancing was completely haywire. The orange bars are below the line by more than 4 and 5 millimeters. So without releasing much ligament, by adjusting only 2 degrees on femur and 1 degree on tibia, we could have a completely balanced knee without releasing the ligament. So this is the beauty of the system where we can preserve all the soft tissue envelope and the patients really do well after that. You can see this post-operative picture. We had planned 3 degrees of tibial slope. We got to 3.6 degree and planned 3 degrees of combined varus. We achieved 2.7 degrees. So our planning and our execution, there is hardly any difference in that. And that is the most important thing about robotics. This is another case. And obviously you have to use technology. Otherwise you have to remove the plate. And it is an osteoporotic rheumatoid patient. So after removal, you have to put a rod. So in such cases, you can preserve the plate and use Navio and put the implant like this. So you can completely preserve all this hardware, which is not touching it. So these are the some advantages. Now let's see what the world has to say, because I have heard in the last 5 years by many colleagues, robotics is a marketing tool. Robotics is nothing but this. Let's see what the literature says. So there are so many papers in the index journals that you will be amazed. The literature is there. If we are saying it is a marketing thing, very well, it may be helping in marketing, but see the scientific advantages. So in this paper, they have done a CT assessment of the post alignment in this thing. They say that excellent precision in sagittal and coronal planes in 3D scan than in robotic assisted surgery. Then current state of navigation, and there's significant role in improving results of uni. Uni, though I am now of opinion that you should not do uni if you don't have technology. It gives you very fantastic results. Advantages of robotic assisted TKR includes greater component accuracy, precision, soft tissue protection, and increased patient satisfaction. This is from Journal of Arthroplasty. Another paper from Arthroplasty, you can see a huge difference that the authors mentioned and found out the robot-assisted group had 3% joint outliers, whereas 20.6 in conventional surgery. Now, all these people are extremely busy surgeons, high-volume surgeons, and most importantly, they are experienced surgeons. So in their hands also, every 1 case out of 4 cases is going out and to the outliers. So whenever there are outliers, you see any literature, you see 20 to 30% outliers. Even this paper in Clinical Orthopaedics and Research mentions that 24% outliers in conventional and no outlier in robotic assisted. Don't you think this is a huge advantage to our patient? Because we all know, nobody can deny that if there are outliers, if there is a positioning of the implants, that is going to wear off and that is going to create an early failure and revision surgery. So we have to accept that this is the most important determinant for survivalship of the implant. You can see even pain, the bleeding, improved functional are better in robotic assisted than jig-based. Robotic technology has shown to optimize precision of bone preparation, component alignment, reducing outliers. So we have so many papers now. You will go on reading about this. This is another very important paper where they have said that the bone and periarticular soft tissue injuries in robotic is much less as compared to the conventional total knee replacement. So they have developed, in fact, this Masti score also, and we are now working on our setup to actually see this, that soft tissue injury part of it. So this is early mobilization pain. So this advantage also is there. As compared to the computer navigation surgery, this author has said it is much more time efficient. It appears to reduce the number of mechanical access outliers. So there are so many papers now. I don't think there is anything to doubt about this now. This was our own paper, which we published in 6 months back, in which we actually showed that the joint line restoration is better in robotic assisted surgery. This is another paper. You can see the joint line elevation is in conventional TKR, but accurately restored using robotic assisted TKR. So there are problems with patella baha, or these type of problems are not there. So joint line restoration, then sagittal and coronal alignment, the robotic technology scores heavily over the conventional knee replacement systems. There are some more papers. I think I will rush through this, and because there are time is limited. So according to this ARCS symposium, it was a sort of a review taken by Parsley, and this was in American Association of Hip and Knee Surgeons. The statement in conclusion was that robotics is here to stay, and at least in healthcare. So I think we are in that journey, and it's a very exciting journey to be in robotics, and definitely time to come, the use of technology is going to definitely be more and more. I think people will be adopting this. When I purchased this robot in 2016, I was the only person doing it for almost 2-3 years. And I understand now there are almost 35 centers pan-India who have resorted to this technology. And definitely in time to come, there will be more and more people to embrace this thing. Yeah, there was a question from Dr. Aditya that, yes, robotic, you can do CR and PS. And actually, I'm doing more CR now with the help of robotics, preserving the PCL also. Robotic can be used for bicruciate retaining. That is going to be next exciting thing around the corner, because that's really fantastic. And in US, Australia, they are using it very commonly. But due to this NPPA guidelines nowadays for rate control, the company is not launching any new product in India. So bicruciate retaining implants are not there. Otherwise, robotics is excellent in this particular thing, where you preserve ACL, PCL, as well as all the ligaments. So I think there will be, what I understand is that towards the end of this year, we will have in Q3 bicruciate retaining implant also. So thank you very much again for inviting me. If there are any questions, I'll be happy to address it.
Thank you, sir. Thank you very much. Nishit, can you please unmute everybody for 1 minute?
Yes, sir. Yes, sir.
Sir, it was an excellent. Please kindly everybody unmute it, sir. It was an excellent presentation. I would like all members of the BOA to kindly applaud the Narendra bhai for his very good presentation. Thank you very much.
Thank you.
It was very excellent presentation, sir. And we are fortunate enough to get a presenter like you over here on this G Merchant Oration lecture. And if there is any question anybody wants to ask, it's open.
You are not unmuted. You have to unmute yourself.
There was one question, I think, in the chat box. I think Dr. Aditya has asked, What are the contraindications for robotics? See, I think the complications, there is no primary contraindication. I've done everything, all cases, but there is, I think, one caution, word of caution rather than contraindication. When I started doing it and we started putting these pins, which are thicker pins than the navigation pins, tracker pins. They are 5.5 millimeters because they have to sustain the vibrating sort of force. We encountered delayed fractures at the pin site, pin insertion site. So now I'm extremely careful in putting these pins in the osteoporotic or osteopenic patient. So now what I do, instead of putting in the diaphyseal region, I put it in the incision and try to prevent that. So that is a word of caution. But in osteoporotic patients, please be very careful in putting those pins. Rest, I think you have no real contraindication to not do the case with robotics.
Sir, one question, Dr. Alpesh.
Yeah.
Sir, as per your data, you suggest, you told that almost 40% of your surgeries are being done by robotics.
Yes.
Sir, in spite and you are still doing the conventional surgeries. Do you
Yes.
think that after doing so many of robotics, your surgical hand has improved and getting more
100%.
accuracy?
Yes, when we use the technology, like previously in 2001, 2, I used to use a lot of navigation also. And that gave us a good sort of a hand and assessment, sort of self-assessment to how much is to release the soft tissue. So it develops, and definitely our judgment improves after we do take help of technology and then go back to your conventional surgery. It improves a lot, means I think, especially on the ligament release side, I think every day we go on learning with a robotic or navigation tool. We get better and better. Like I did some case last week, which was a 20 degrees flexion deformity, and we planned to take some bone more. And what it was saying, it don't take this much bone. And because earlier I used to take 2 millimeters or 3 millimeters in conventional. And then just by release, the robot could tell us that this was not necessary. So these are small points, but I think every day we become even more knowledgeable.
Sir, if a choice is given to you, how would you select the patient to go for navigation or robotic? Means what?
Actually, now I have now completely moved from navigation. Very rarely, if a person wants debut implant, I have the kick system with me. So only patients who want a particular implant, I will use that. The knee 3 of is quite good software in this kick system, so you can use that. There are secondly non-academic factors like the packages, and if the patient is not affording or in some scheme, something like that, then you can't do robotics because there is a cost of 25,000-30,000 which is added for a particular case. Then some people say nahi conventional karna ya navigated karna. That is the thing. But first option what we give is the robotic surgery.
Okay. Sir, anybody who would like to tell something about the GV Merchant, any incident or any story as a student, as a teacher who has been under the Dr. Merchant? Anybody? Raju bhai? Arasha? Sir, kindly unmute it.
Sejal, I don't have any personal experience because Dr. Merchant retired when I was an undergraduate.
Okay. Ashok bhaiya and I think Ashok bhaiya and Mehta sahib has gone.
Mrugank is there. Mrugank can.
Yes, Mrugank bhai.
He has set up a very good hospital, and Dr. Merchant was really, the pioneer of orthopedics in Vadodara.
Yes, sir.
He did so many things in orthopedics which were, far ahead of time in those times.
Mrugank bhai, yes, sir.
For me to be very objective about him is difficult, obviously, because I have grown up in the family as he was my father. So to be objective about one's father becomes very difficult. But I
Yes.
also then studied under him for some time as a undergraduate. And then I was in his ward, in his unit. What I had not learned directly from him as a postgraduate, I learned from his students, which was his legacy. And I can tell you that whatever things, surgical techniques that I learned, basically, no touch technique, respect of soft tissues, it made significant difference in those days because infection was a major issue of concern, particularly in SSG hospital. You know how the government hospitals run and how difficult it is to control infections in that kind of setup with the kind of patients you get. What I found was that, and what my teachers told me was that there was a significant difference in infection rates under his hands. And of course, apart from that, his concept, bone concept, his anatomy was so profound because he told me he used to as a when I was assisting him afterwards, when we started working together in private, he used to tell me that he had, when he was studying anatomy in those days, he had spent in the first years almost 80% of his time in anatomy dissection halls and anatomy books. So those were the kind of things that made a difference. Of course, he was very enthusiastic, very dedicated, very sincere. And so he could have started his private practice much early, but continued to work in the government hospital almost full time and did most of his surgeries there. In fact, a lot of his patients still tell me even today that he could have operated, they wanted him to operate in private hospitals. He was allowed to do that, but he would insist on bringing them back to the SSG hospital for surgery. So those are some of the few memories I have of him. Of course, I could keep on talking about it for a long time, but
Yes, sir.
I need to be also a little objective. So I'll stop here.
Yes. Yes, but thanks a lot for sharing us such a good things about him. And we have one more with us, Mr. Govind Purohit, Dr. Govind Purohit from Ahmedabad.
Good morning, everybody. I am Dr. Govind Purohit from Ahmedabad. I have one experience of Dr. Marchand sir when I was in second MBBS studying in Ahmedabad. Okay. My uncle Ramubhai Purohit residing in Baroda had fractured tibia. Yes. And at that time in 1976, fractured tibia, and he developed compartment syndrome, I remember. Okay. And he was operated for fasciotomy. Now, in those days, it was very difficult to control the fasciotomy, its infection, and the amputation rate was very high at that time. But I saw Dr. Marchand sir taking rounds. He was very disciplined. Dressings by residents was being performed with all aseptic precautions which we are following today. So I have full respect for him. And my uncle recently expired before 1 year, but all these years he had no problem. He was walking, running, all activities he was doing after fractured tibia in 1976 or 77, if I remember correctly, probably. And I have all the regards for the sir, and I still remember the incidents with him. I stayed there for 7 days, and I had seen him taking rounds with the residents. He was very strict and disciplined.
Yes.
Thank you all for listening to me. Thank you.
Yeah, thanks a lot for going by. Yeah, same thing I have heard from my patients and from my senior doctor colleagues also. He was very much strict and disciplined, particularly in the orthopedic and in orthopedic wards and department also. And not only that, he was also very much dynamic in growing the students for the learning from the literature and from the scientific materials also. So he was a wonderful person also, and a solid teacher. I will say just teacher. He was an excellent teacher.
He did not allow any of the relatives during the round, and no objects should remain under the cot even. He used to throw out of the window. I have seen him actually himself. And even then he was favored by the relatives and the patients actually.
After he retired 3 years later, we were, he and myself, we were walking down the corridor of B3 ward, and the guy, young boy with the kettle, tea vendor, young little boy was coming, as they always come to serve tea to the patient's relatives unofficially. And the moment he saw my father, he put the kettle, the cups, everything, and ran away.
Oh.
Because if any such person came when he was there, the cups and the kettle was confiscated, and the fellow had to do 100 squats before he could go back.
That's true.
He was quite very disciplined.
Yeah, very disciplined. Very disciplined.
Yes. Thanks for sharing a wonderful moments with our beloved teacher. And now we will move on.
At that time, Dr. Kshatriya was there as registrar. I remember Dr. Kshatriya was the registrar at that time.
Unfortunately, he is also no more now.
Yeah, I know.
Yes.
Yeah.
Okay. Yes. Okay, now we will move on from the oration lecture to our next lecture by Dr. Ashish Babhulkar, sir, for the replacement in the proximal fracture. I will just introduce Dr. Ashish Babhulkar. He is the head of Department of the Shoulder and Sports Injury in Dinanath Mangeshkar Hospital, Pune. And he is a founder, president of Shoulder and Elbow Society of India, and F&B Sports Medicine train program director. And he is also director of the Shoulder Conclave, which was held biennially, editorial board of the BESS Shoulder and Elbow Journal. And he is also pioneer in the reverse shoulder arthroplasty in 2009, open latar jet in 2005, arthroscopic latar jet in 2013, and AC joint biological implant-free reconstruction in 2002. He is also, apart from the academic, he is also a marathon runner with 1.6 for half marathon. That is excellent, sir. Superb. And advanced scuba diver with 76 dive. That is superb. And also he is a calisthenic follower and occasional calligraphic artist. That is this is something different from an orthopedic point of view. Superb. And he is a ninja warrior also. In short, he is, apart from orthopedic, he is a lot more. I welcome you on behalf of Baroda Orthopaedic Association, sir, for your talk on the replacement of the shoulder fracture, proximal fracture shoulder. Thanks a lot, sir. And welcome, sir.
Thank you, Sejal bhai, and thank you for this honor on behalf of Baroda Orthopaedic Association. So we'll take you to a level above the waist. So we'll discuss about shoulder replacement, specifically in fractures, because this is a completely different topic than doing replacements in elective conditions. The replacements in fractures is always looked with skepticism for shoulders, because things are not clear which fractures should be done. In the past, there were no alternatives to hemi, and there were several processes, and still confusing. You must understand that the knee has been researched almost 50 years ahead. And as Narendra said, if you look at the different knee implants or prostheses, all of them are of the same principle design. Nobody has the guts to tweak any of it. Much capital condom, all that research has been done, but shoulder replacement is still fluid, and we're still continuing to improvise on our results. But one thing is clear: if the rotator cuff is good, only then can you give a good result on hemiarthroplasty. Otherwise, the results are a complete disaster. The other problem with replacement in shoulders is that the results are not consistent and not predictable. So we need to look into why this is so unpredictable in these patients. So one looks at a 74-year-old diabetic and you see there's a 4-part fracture there, and we think this is doable. What we don't often understand is the quality of the bone. And sometimes it is an eggshell and you go in and there's nothing holding and everything falls apart into a varus collapse within 3 weeks of fixation. A lot of my shoulder colleagues in Europe and in Australia have given up the hemiarthroplasty for fractures because of the inability to give consistent results. But that is not true. So we continue to provide hemiarthroplasty for fractures, especially in the young patients. But I will try and sift data and get you to look at the wheat from the shaft so that we understand what is the problem here. So in terms of indications, we are largely going to look into 4-part anatomical fracture dislocations, failed Philos fixations, failed conservative treatment where there's no function, and of course, the late secondary osteoarthritis because of prominent hardware and chronic deformities. The X-ray you look here is a 73-year-old diabetic operated 3 years back. Technically, this should have been a straightforward fracture. It should have healed. But by now, her soft tissues are all completely degenerate. She has only 20 degrees of active movement, extreme pain. This is not salvageable because the soft tissues have gone for a toss completely. So a good result in a hemiarthroplasty is you must not look for a good result on the X-ray. I would rather have a good result in terms of function, that the patient is able to reach her hand, has a good strength, and able to perform her radials and multiple activities. So radiological healing versus functional recovery is the argument that we are trying to propose. The whole idea of the surgeon in doing a hemiarthroplasty is to provide a 3D reconstruction of the original native anatomy. So it's not that you pick up a prosthesis, which is a monoblock, and then one size fits all, and you put a 30-degree version for everybody. That is bound to fail in a majority of patients. The results in trauma, you must read, is the results of greater tuberosity integration with the shaft. So that is what gives us a bad reputation. So if we can achieve a greater tuberosity integration into the shaft or humerus, I think most of the problems are done. Tuberosities definitely win matches. The other thing is doing a hemiarthroplasty for a fresh fracture and doing a hemiarthroplasty for a failed fixation or a failed conservative treatment is completely chalk and cheese. So soft tissues are critical in the shoulder. And that is why if a decision has to be made, it should be on day one, not as a fallback decision. Now, why is hemiarthroplasty in trauma much different from a hemiarthroplasty in osteoarthritis? Because in a trauma, proximal fracture humerus situation, there are no landmarks. We don't know what is the quality of the rotator cuff. It is impossible to test it preoperatively. The head cut has been taken by nature, not by the surgeon. Version is a complicated issue. We will not talk too much in detail, but I can tell you one thing, amongst the 30-odd people that we are here today, each of us has a unique version. So I cannot just put in one 30-degree version for all of us because 2/3 of the time it will be wrong. So it is utopian to believe that a 30-degree version works, and that is how we were taught, and that is how all our hemiarthroplasties were done. The hemi patients are really much younger patients. So technically in our series, they give a much better result, really speaking. So this is a 60-year-old chap who came in 6 weeks late from Indore. You can see not only is it a 4-part, multi-part fracture, but it's a head split fracture. So clearly this is not salvageable, and there should be no two doubts about what we ought to do for this. When you do a hemiarthroplasty, the conventional hemiarthroplasties were smooth stems, so they had to be cemented. But if you look clearly here, it is the GT which should sit in there, and it should sit there as if it belongs into that hole. If we can achieve that, then we have done our job. That's very important. So this paper spoiled everything and gave hemiarthroplasty a completely bad name, where this is a senior gentleman who has the most experienced shoulder surgeon in Nice in France. And he said 23% patients had GT detached, even though they had initial correct positioning. But if you look closely into this paper, you'll realize that most of these who failed were females above 75 years old. Very important pertinent point in that series was that retroversion is not individual, not 20 degrees as it was proposed. It should be native version for every patient to be able for that GT to stay in position. To ensure that the GT goes in position, there are several devices like these. These are bulky, tedious to use, and in a small incision cannot allow us fracture instrumentation. Instead, what we prefer to is this is a stem that we helped design for Evolutis France, where you can see this is the reamer. And on the reamer, you can see that there are these slots which exactly match the slots on the final stem. So that's critical so that we know the exact height during the trial reduction. This is a conventional reamer which has no slots here. Not only that, the trauma stem has a slot here for the circumflage wire. You have a HA coating proximally, and you have a honeycomb appearance here, which will create a nice friction fit for the tuberosities to want to stay. A tuberosity will never heal to a smooth stem, but it will integrate to a HA coated stem. In addition, we augmented our chances of GT retention by designing a cerclage knot, which was very critical in retaining a GT. So this is in a 90-degree plane, orthogonal plane to the conventional GT sutures, and we accepted the niece knot technique. We actually published a paper for the niece knot and proved that the niece knot is better than your conventional knot. So this is a gentleman, 62 years now, 9 years post-left hemiarthroplasty, and still retaining, doing well. And that's difficult to achieve because convention and history suggest that after 5 years, the results start dropping down. So just to give you a taste of other options, because within this 15-minute ambit, I need to cover a lot. This is a 60-year-old lady and very fit lady, does a lot of yoga and stuff. So she was keen not to have a replacement, and she had a complex fracture, osteoporosis, hypothyroid, and on steroids. So what we've done for her is something called as a in-between implant. So this is just unique. And what we've done here is kept the implant within and retained the patient's head and the tuberosity, and that still has allowed her to achieve her. She's a yoga trainer, and it was critical that she continues her profession as before. So this is her result 2 years post-op, and she can continue. There are no restrictions to her. It is not a panacea for every fracture. For this is for in-between fractures, which are complex, and younger patients where you don't want to do. What about elderly patients? Consistently, patients above 70 have a high level of complication after proximal humerus fractures. So as a thumb rule, we would not do fixation. We would either conserve them or do a reverse shoulder replacement. There are exceptions. There are patients who are 72 and physiologically they're 65 because they're playing golf and playing tennis. Those are different patients. I'm saying osteoporotic patients who are 75 and above. This is a lady who had a bilateral fracture at different time intervals. First time she came in, we did her left shoulder lock plate, and we've achieved a good result, anatomical healing, AP and lateral. But by the time she came back, she had cardiac disease, she had osteoporosis, she had asthma, and she was on steroids. And we thought this is not the right time because her cuff is poorer on this side. She struggled to get her function back on the left for almost 6 months. So we did a reverse shoulder. She has a fairly similar range of movement both sides, but she is much happier with the pain relief and the strength on the right side. So this makes sense. This is 81-year-old, just a standard 3-part fracture. This is eminently fixable. Most surgeons would use a plate here, but we don't understand the quality of the bone. But more important than the quality of bone, the rotator cuff is dysfunctional at 81. Without the rotator cuff, whatever you do, whether you do a just unique, a hemi, or fixation, is going to fail dramatically. And in this age group, you just want one operation to solve everything completely. So this reverse shoulder is an ideal implant for these patients. And this is her 4-year follow-up now. And she's still looking, she's an active lady, South Indian. And she looks after her son's company. She looks after the finance and still doing well 4 years down the line. I think this makes sense to get them out and start moving, no immobilization, because this age group is one where you want them to do everything physiologically and make them independent. She lives alone on her own self. So finally, the taste breaker for today's talk. I should have talked a lot more on this given the topic that we started with, the robotic, but I thought these were important points that had to be highlighted. We have slowly moved on to technology and we are not technology agnostic. So the HoloLens 2 is a very fancy new device that is developed by Microsoft, and it has been integrated by Evolutis for the shoulder replacement technology. And so to give you a concept, the HoloLens allows me to visualize the 3D imaging and the surgical technique of this prosthesis. So basically, when you do a 3D CT scan, you print that on a 2D paper. So we are looking at different 3D images on a 2D paper. Whereas here on the lens, on my right side, I have the entire 3D CT scan of the patient, and I can enlarge it, I can reduce it, I can turn it, twist it, make it upside down with my hands in a sterile field. In addition to that, because I'm on the HoloLens, I can transmit this live, and you can sit there and get my field of vision and see my surgery exactly as it is without any cameras interfering with the field or violating the sterile field. Number 3, at the same time, I can be remotely handheld by a surgeon from France and UK, which was what we did in the first week of December, and they were tweaking my surgery sitting there. And lastly, I can have the entire manual of surgery on my left side in the air so that I can check the next step and find out how it is to be done if required. So this is just a taste of what we did with this patient. So I had...
So just a little detail about the patient. This is a 70-year-old lady and she's been suffering from 3 years.
So I'm discussing this with Thomas Gregory and another UK surgeon. Thomas is from Paris and France. And I'm showing him all that. This is a pointer. This is my finger. The finger comes out with a laser pointer automatically, and I'm discussing the x-rays and I'm swiping them. So we've got the whole pre-op plan right in front of us. So you are getting the exact view that my helmet has. And I'm showing him that that osteophyte is large, very close to the axillary nerve. And then we are discussing the version here of the glenoid and the fact that there's about a 7-degree retroversion which needs to be corrected. And there are different techniques of doing that as such. So this is the highest level of technology available right now for shoulder replacements. And just here, I'm talking them out. And
you present the case. Okay, there is 5 minutes where you speak about the HoloLens.
The French surgeon, where we are discussing what are the options for this surgery. Watch here closely. I have the 3D model right on front of me. The left one, the fair one, is the model, which is normal shoulder. And this is the actual 3D CT scan, which I place it on this board here underneath the glenoid tine. And I can correct it, twist it, put it up there. I can segregate the humerus separately, the glenoid separately, and then see for myself, rotate it, and keep that as my reference model. I can pull it right in front of me and magnify it as much as I want without violating any of the surgical fields. And then here, I'm showing him the surgical technique. He wants to know what is the next step after inserting the K-wire. So on the 3D hologram on your top left corner, the K-wire has been inserted, and we want to know how do we understand that the K-wire goes bank central. So this is the reamer that comes through on the K-wire. So I remember that this is how the technique is. And since it belongs to the patient, then I know exactly where the center point is, because everything depends on the center point as such. This is the another maverick thing that you can do, because this is the patient who had that 7-degree retroversion. I am catching the subtracted glenoid, not the entire shoulder model. This is the subtracted glenoid which I've taken up, and I'm playing around with it, and I'm positioning it exactly as the patient's glenoid is, so that I can evaluate where my guide wire goes. So this is called as off-center reaming or eccentric reaming. Because there's a 7-degree retroversion, I will not put my K-wire straight in the center. So I'll put it off-center, slightly anteriorly, so that I can ream more anterior and less posterior. So this again allows me a co-planing based on technology as such. So this is just a taste breaker for this. I've not discussed too much of literature because of the shortage of time, but this is one paper that I would highlight, that there are pros and cons between hemi and reverse across the board. What you need to understand, and to cut a long story short, is that patients above 70, it's preferable to do a reverse shoulder replacement. Patients less than 60, you would prefer to fix. And between that 60 to 70 group, if the rotator cuff is good, the hemi is good, because the reverse had a more consistent restoration on UCLA scores. You can see 29 over 21, and they have a better forward flexion of 120 over 80, but the rotations were worse than the hemi. So of course the hemi is far superior. It should not be junked into the bin yet, because that is anatomical and should be the first option, provided you are an experienced shoulder surgeon and the rotator cuffs of good quality, and you have the surgical skills to get the greater tuberosity integrated into the humerus. So the bad results for patients in HEMIs are all mostly patients above 70. And that's why it's much preferable that you just do a direct reverse shoulder replacement for these patients. In conclusion, you must have CT scans for all your proximal humerus fractures because they give you a much higher level of information than a conventional CT. Technically, it's an intra-articular fracture, and that's why I would do that for all. Again, it is much more soft tissue balancing than a TKR. The shoulder results are skewed between different surgeons because it depends on how well they can integrate the soft tissues, especially the GT and the LT, which is the key to success. Very elderly patients, I would do a primary reverse shoulder for them. But a tale of warning that surgery offers the best chance for good outcome, but the worst complications of proximal humerus come from unsuccessful surgery. So do be careful on that. I hope this was useful. Please join me on the 24-hour holographic surgery platform. This is led by Microsoft. What we are doing is across the world in 15 different countries, surgeons are going to start operating from early morning till late night based on GMT. And so you'll have a taste of at least 15 different surgeons presenting different new techniques where there's a holographic integration. All of them are going to be wearing the HoloLens too. So it's a unique event. And I would be happy if most of you can come and attend that online event. Thank you very much for this opportunity.
Thank you for sharing such a wonderful and excellent presentation on this holographic lamp, holograph lens. And we would like to have a few more questions for this thing. But main important thing is this holographic lens is very useful even in the soft tissues also. How can we, what about soft tissues?
So there are, Sejal, different technologies in the shoulder. The navigation is separate, holography is separate. Yes. We deal with a much more complicated challenge because the shoulder glenoid is movable, unlike the hip and acetabulum, which is fixed. So every patient has a different orientation. And that's why there are a lot of errors. Most important problem is that the glenoid is just 25 mm, which is the size of my thumb. So my guide wire insertion has to be spot on in the center, aligned in 3 dimensions. And that is where all the errors come. This is where holography comes in and helps me assist. When I'm looking at 2D images printed on films, and then I'm imagining what is the angle I have to draw. Whereas I have the 3D image right in front of me, which is magnified, I'm less likely to make an error. Navigation also helps us do that. Eventually, see, we must understand that none of us can afford to be technology agnostic. We all had a landline phone. We were reluctant to use those big, heavy mobile phones. But look today, where are landlines? They are in our bin. Whether you want it or not, it is going to come. So eventually the next step will be integrating navigation with HoloLens. So we'll have everything. That helmet is like a powerful Apple MacBook laptop. It has everything. You just have to feed all the correct data into it. So we're getting used to it because there's a lot of gesture control, a lot of PlayStation, and then you're doing 2-3 things simultaneously. So you're multitasking as well. So if you're a female shoulder surgeon who used a lot of PlayStation, you'd be adept at playing HoloLens.
Yes, that's true. How much cases you have done with this thing, sir?
We started training in July. We've done 4 cases. We still have to integrate the technology of converting DICOM images to STB images. We have the technology now, then we can do it. And it is not expensive at all. HoloLens costs like 8-9 lakh rupees only. The availability is a problem. So it is not a very expensive. Cost efficiency ratio is excellent.
And less bulky instrumentation and less bulky the machines will be also.
Absolutely. There's nothing. There's just that helmet and it is remote cordless. That's it.
Yes, that's good. It's good. Any more questions? I will just check the chat box. Any questions regarding this thing? Okay, fine. We will now end our session. Before that, I will ask Dr. Alpesh to deliver a memento for the GV Merchant Oration lecture to Dr. Narendra Bhai. Narendra Bhai, yes. We will just give you virtually at present, sir, and we will just courier it later on. Yes, this is the kindly everybody clap. We will send you virtually, or we will send you by the courier next
Sure,
week,
sure.
sir.
Absolutely. Pleasure.
Mute, chair, mute. Hello. Alpesh, you are mute. Alpesh, you are mute. Kindly unmute yourself.
Sorry.
Yes.
It was a great pleasure to have Dr. Narendra Bhai Vaidya as a chief speaker of the Oration. And on behalf of Baroda Orthopedic Association, we would like to submit, and soon we will courier this memento to you, sir.
Thank you. Thank you very much.
And say it was a pleasure, and it was great of you that you sacrificed your Sunday a few hours for us and delivering such a wonderful topic which was not quite heard. I think many of surgeons were knowing very bleak idea of navigation, robotics in arthroplasty. But now this has opened the doors and widened our thinking.
Thank you, sir.
And sir, soon we will sending you this letter of thanks also. That would to be delivered along with that, sir.
Thank you. Thank you very much.
And also, Dr. Ashish Babhulkar, thank you very much for spending your valuable time and
nice learning.
Giving us nice learning and giving a good academic feast regarding the proximal shoulder, which we are regularly doing, but still we'll end up in problem, and still we are learning daily new things, sir. Thank you very much,
sure.
Sir.
Thank you. Welcome.
Thank you, sir, and thank you, everybody. Thank you once again, Narendra Bhai, for an excellent talk. And we learn a lot, many things. That if you want to earn not only the money, but if you want to earn the name, fame, and the good health of the people, you need to learn a lot. So thanks for the learning which is given by you today. And thank you, Mrugang Bhai, for giving us this platform of the GV Merchant Oration lecture.
Thank you.
And it is only by the sirs teaching and learning that we achieve all these things. Thanks, Alembic, and thank you, Dr. Paratkar, also for cooperating and giving us the guidance for this thing. And thank you, my team of BOAC and BOA members too. Thank you all. Thanks a lot.
Thank you.
We are completing our session. Thank you. Thanks a lot.
Thank you. Thank you
very much. And have a great day.
Thank you.
Thank you, Ashish Bhai.
Thank you, Narendra Bhai, Ashish Bhai.
Thank you. Thank you very much. It was a pleasure.
Thank you, Merchant Sahib.
Thanks to the Alembic team also for providing us the platform.
Welcome, sir. Thank you, sir. Thank you. Thanks, sir. Welcome, sir. કાલે ઉપરનું મૂક્યા હતા ને તઈ જોઈ લઉં ના રવા દો બંધ ના કરતા છોડો રવા દો કાલે
Yes.